Male cancer patients have 80% of their estrogen comes from peripheral conversion and 20% comes from their testicular excretion. It's very different than women. Obviously, most of the production in women, premenopausal women, is ovarian function, and then postmenopausal women is from peripheral conversion. Now, when they looked at women and men, the amount of peripheral conversion men are actually higher than postmenopausal women. So one of the things that there are studies that have looked at, tamoxifen effect versus AI, and one of the things that they have found is that there's something called an estrogen surge. When an aromatase inhibitor inhibits estradiol, which is the active form of estrogen, there's actually a loophole, a feedback loop through the luteinizing hormone and the FSH hormones that stimulate testosterone levels, and that increase in testosterone increases estrogen production. And there are two ways that the AI, actually, we thought that the function of the aromatase inhibitors was mainly by decreasing estradiol, but in men, it doesn't work like women. There's actually a loop that causes a LH and FSH increase, and then that increases testosterone and therefore increases the circulating estrogen. And also the testicular secretion of estrogen is not impacted by AI. So one of the things that AI has been looked at is with combination of gonadotropin releasing hormone analogs, and actually the small studies that have looked at this have only found partial response, about 25% response compared to tamoxifen, which has better outcomes. So currently the standard of therapy and the recommendation is to give tamoxifen for 5 years for all male breast cancer patients. Now the ETHAN study that is going to start accruing now in 2024 is a randomized controlled trial that's prospective, and it's going to look at not only tamoxifen but also AI with gonadotropin releasing hormones, and also looking at CDK4 inhibitors for male cancer patients. We have only data to support tamoxifen thus far. The aromatase inhibitors in men has been shown to be inferior when it comes to disease-free survival, and also for effect on the actual estrogen conversion. So right now, the tamoxifen is the one thing that we normally recommend for patients with male breast cancer because it has increased disease-free survival, overall survival. Now, unfortunately, there's only, I would say that 70% of patients who qualify for estrogen blockade are prescribed, and out of those 70% that are prescribed, only 70% actually take it, with studies finding that 50% of them have stopped taking it by 5 years because of side effects. So there's there's that controversy, but also that limiting factor that there's people that don't get it, and the people that get it, a lot of them fall off. So I talked about the ETHAN trial that's starting accrual this year, and they're going to incorporate the CDK4 and 6 inhibitors for patients with male breast cancer. This is going to be the only study out there that's going to look at this in the prospective setting and the randomized setting, which is going to be very significant for male cancer patients. The limitations right now is that there was no patients that were incorporated in the RespondrRx, the MENDAC, and the TAILORx studies for the Oncotype. And there's no studies that are out there also incorporating the MammaPrint. So right now we're really basing our treatment and our recommendations on data that was for female breast cancer. To be honest, one of the things that we talk about is that in the node-negative population, we could use it, but in the node-positive population, we should not. And maybe when we do studies looking at male breast cancer patients, the Oncotype score may still be used, but maybe the ranges will be different. Because one of the SEER database found that patients who have a 21 score on the Oncotype, which we consider low score for no chemo needed, had worse overall survival. And so that's something that we need to look at with more granular data. One of the things that the male breast cancer consortium study looked at, they did a retrospective study of 1,800 patients, and they looked at that male obviously were more likely to be diagnosed at a later stage, were more likely to be estrogen positive, that it had low compliance, about 70% to estrogen blocker, but they found that there were 5 subgroups that were linked to male breast cancer, and one subtype was specific to men. And I think that that's probably something that should be looked into, because that's going to change the way that we see this patient population, and we're able to treat them with a more individualized care.